Good afternoon, everybody, and welcome to the webinar, Elder Abuse Prevention and Response, the key role of medical professionals in identifying, reporting, and treating elder abuse. We've been working on this project and this webinar for a while, it seems, and so we're really excited to have you with us today. Just a few housekeeping things before we start moving through the slides. If you would, please rename yourself on a Zoom call by hovering in the upper right-hand corner of your picture and put your exact name. It'll be compared to the claims for continuing ed. And if your name doesn't match, then we might have some trouble there. So make sure it's your first and your last name and the name you're going to use when you claim your continuing ed credits. Also, just we'll get there, but put your questions in the chat box. I'll be monitoring those as we go on, and we're going to hold the questions until the end of all three presenters' presentations and address those at the end. Some might get answered, during the presentation. So we'll save those all up for the end. So next slide, Sydney. So none of our planners or presenters today have any financial interest or arrangement or affiliation that could be perceived as a conflict of interest. So that's Sydney Palinkas, Greg Cesek, and Ray Leonard. Next. And then to claim your credits, you will need to follow these instructions on this slide. You will have 30 days from the date of today to claim your credits. You'll go into this website and then complete your evaluation to claim your credits. You will not be issued any credits if you're based on sign-in sheets, including pharmacy, effective immediately. So make sure those names match up with how you're going to claim those. You have these slides available to you, and I'll remind you about this again at the end. But make sure that you do claim your credits within a month. I always like to do it right away so I don't forget. All right, next slide. So just a little bit about the Maryland Patient Safety Center. For those that don't know, Maryland Patient Safety Center is a not-for-profit organization in Maryland. We've been around for almost 20 years. Next year will be 20 years. And we provide education, collaboratives, resources to healthcare providers across the healthcare continuum. So what we do is we service the healthcare providers and provide conferences. So please take a look at our website, and there's a number of resources there for you. And if you have any other questions about us, feel free to email me. You've all got my email address because I sent you the Zoom link. So make sure you follow up with us and we can tell you way more about it on a one-to-one level. So today's presenters are Sydney Palinkas. She is the Associate Director of ElderSafe, the ElderSafe Center at the Charles E. Smith Life Communities. Ray Leonard is a manager of abuse and domestic violence and sexual assault. I need to move my little picture thing. I think it's saying promotion or prevention programs at Luminous Health Anne Arundel Medical Center. And then Greg Cesek, or I think it's Cesek, am I saying it right? Yay! Office of Adult Services for the Maryland Department of Human Services. So we're really honored to have all three of these presenting to us today. Next. So without further ado, I'll turn it over to Sydney, who will be our first speaker.
Thank you so much, Bonnie, and thank you all for joining us. So just a little bit of background about ElderSafe and where I'm joining from today before we get into the meat of the presentation. For those of you that maybe aren't familiar, ElderSafe is part of Charles E. Smith Life Communities. We're located in Montgomery County, and we're serving older adults throughout the entire Maryland, DC, and Northern Virginia area that are experiencing any form of elder abuse. So we have a helpline that you all are welcome to call if you're ever concerned about someone that you're working with. And we always try to remind folks that we are not replacing adult protective services with this helpline, but we can provide additional resources. We can also provide temporary safe shelter on our campus, and I'll tell you a little bit more about that, as well as provide free community education and advocacy. So our shelter program is located within our long-term care campus, and we're able to serve folks either in a private nursing home room or a private apartment, just depending on their skill level. So this is the general eligibility for shelter, 60 years or older. It's a little bit of flexibility there. If someone was, say, 55 and had some complex health needs that made sense for our campus. They have to be experiencing one or more forms of abuse. They have to be willing to come to shelter, which is often one of the biggest barriers. People aren't ready to make that move. And they have to be willing to agree not to contact their abuser during shelter stay. And we do that for a couple of reasons, one of which is it's often very high lethality cases, and we want to protect our entire campus. We are financially blind, so we do accept clients without insurance. That's not a barrier coming in. Due to our grants, however, we can't take cases that are strictly self-neglect or homelessness cases that are not tied to abuse. So if someone is experiencing abuse or experiencing homelessness due to the abuse, that could be a case for us. But if they're experiencing chronic homelessness, say due to poverty, that wouldn't be a case for Elder Safe Shelter, but we could certainly provide referrals to other resources. While they're in shelter, they have access to all of the same services any other resident on our campus would have, which includes medical care, psychological care, access to physical, occupational, and speech therapy, as well as spiritual support. We work with them on legal referrals if they're looking to get a change of guardianship or divorce or a protection order. We work with them on specialized trauma therapy. A lot of folks, as I'm sure you can imagine, are coming in with pretty severe trauma, depression, PTSD. So we hook them up with trauma specialized therapists. And for those folks that maybe aren't able to take part in traditional talk therapy, we also have a holistic therapy program, which is yoga, music, and art. And then we work with them on a safe discharge and figure out where their next steps are going to be. All right, so I'm going to get into the meat of the presentation here of what is elder abuse. And as you can see, this is a pretty hefty definition, so we're really going to kind of break it down throughout the next hour and a half. But elder abuse includes physical abuse, sexual, psychological abuse, neglect, abandonment, and financial exploitation. It can happen in any setting, so in a private home, out in the community, or in a facility. And the key here really is that it's happening in a relationship where there was some expectation of trust, right? The older adult expected to be able to trust this caregiver, their son-in-law, this person calling up and selling them insurance, and then that trust is exploited. So before we move forward, we're going to go just do a short poll to look at some of the myths and misconceptions about elder abuse. So take a few seconds here. There's 5 questions, all just true or false. Let us know what you think. All right, I'm going to give it a couple more seconds. We have almost everybody who's participated. All right, so let's go through these. The first one, most elder abuse is perpetrated by professional caregivers. So most people said false, a couple true, and some I don't know. Most elder abuse really is committed by someone within the family, right? Whether it's a spouse, an adult child, niece, nephew, grandchild, and sometimes that person is providing a caregiving role, but it's often not a professional person. Next one, most elder abuse is caused by caregiver stress. All right, so a lot of people said true for this one, and this is definitely a big myth that we have out there about elder abuse. The idea that it's a caregiver who is just super stressed out, gets a little bit out of control, and hurts that person. And that's actually not what we generally see when we're talking about elder abuse. Often, when caregivers are becoming very stressed, they're actually harming themselves a lot more than they are harming the other person, right? They're not eating well, they're not doing their own self care. It's not as common that they're kind of lashing out on the other person. And when we really start to look at elder abuse cases, it's less about someone losing control and more pretty thought out actions that these abusers are taking against the person that they're hurting. And you'll start to see that as we go through it. And that's not to say that caregiver stress is not real and not a problem, but sometimes when we put too much focus on that as the cause, we lose focus of the survivors themselves and the services that they need. So the next one, if the older adult says they're not experiencing abuse, then it didn't happen. Perfect. 100% said false, which is great. That is definitely not true. There's so many reasons that older adults and any survivors of abuse might say that they're not experiencing this. Elder abuse is not as serious as other forms of violence, like domestic violence, child abuse, etc. So we had a couple true, mostly false, though, which is definitely correct. I think this is a big myth that we see, that it's not something to be taken as seriously, not as big of a deal. The consequences aren't as huge. And as you'll see, it definitely has a very severe impact on the people that are experiencing it, their families, and the whole community. And then elder abuse is not common. Yeah, so most people said false here, which is also true. Elder abuse is very, very common, and I think we'll get to the stats on the next page here. So thank you all for being a little interactive. All right, so elder abuse affects about 5 million people every single year, which works out to about 1 in 10 older adults experiencing abuse in their homes. However, we're really only seeing the tip of the iceberg here in terms of cases, because only 4% of cases are ever reported. And that's really one of the big goals I think of in Elder Safe and our community education, is trying to get this entire iceberg up above the surface so all of those older adults can reach safety and really make their own decisions on how they want to live the rest of their lives. These are just some quick stats from Maryland specifically. It's from FY20, so a little bit dated, but just gives you an idea of the general breakdown of the different types of abuse that we're seeing specifically in Maryland and how those are reported. So as you can see, neglect and physical abuse are high up there. Sexual abuse is lower, and we'll talk more about why that is often underreported. So as you can imagine, the risk of elder abuse really increased during COVID due to the social isolation and the loneliness. People just weren't getting out. They weren't able to see anyone to make those reports or to tell anyone what was going on. And often they were either left home all day completely alone, right? So vulnerable to stranger scams or a friendly neighbor coming over and taking advantage. Or maybe they were left home all day long with this abuser who now also has their own heightened stress due to COVID and financial issues. And then they're never getting any respite away from this abusive situation. So I'm sure more studies will come out, but one study that came out looking at self-reports found that 1 in 5 older adults were reporting elder abuse during the pandemic, which is really, really staggering. And I'm sure we're still seeing all the results of that and what that impact is going to be in all of our programs. So what impact does elder abuse have on the individual? Well, people are at 300% higher risk of early death compared to those that have not been experiencing abuse. They're more likely to be admitted to the hospital, more likely to need nursing home level care. So they might have been able to live independently before this abuse, and then due to the toll that it takes on their body, they're no longer able to. We also see increased mental impairment, dehydration, malnutrition, issues in people's sleep. Pre-existing conditions often get worse. They're more likely to use emergency services, more likely to have pretty severe mental health challenges like depression, anxiety, PTSD, isolation. And we've seen a pretty big increase in suicidality in terms of our helpline calls among victims. And they're also experiencing really significant financial losses, right? Sometimes people are coming in with literally just the clothes that they are wearing when they get to the hospital after they come to us. They have nothing else. They're losing tens of thousands of dollars, sometimes all of their savings. So they're really, really reliant on social programs after this often, due to this big toll that it takes on their body, due to the big financial costs. So for those of us where it doesn't really hit our heartstrings here, it's definitely hitting all of us economically. And I think we need to, look at all of this and see that elder abuse is really a public health issue and kind of try to reframe it in our minds. So who commits this abuse? We already covered this a little bit, but it could be current or former spouses or dating partners. So sometimes people have been in these relationships for 40, 50 years. It might have always been violent. Maybe it's changed a little bit over time, but now, in later age, they're finally able to leave, or maybe there was some sort of last straw and they got out of that relationship. We also see abuse from other family members. So grandchildren, children, nieces, nephews, siblings, kind of anyone within that family unit. And this is where most of the abuse is taking place within these first two bullets. We also see abuse, of course, from caregivers, professionals in people's lives, whether that's professional caregivers, people that are supposed to be helping them financially, maybe someone at a day center or senior center or facility that they live at, neighbors, friends, and then of course, strangers. We spend a lot of time talking about stranger scams, at least I do, out of the senior centers, but it's certainly a pretty small number compared to this abuse that we see from those trusted people. Okay. So older adults have some unique vulnerabilities compared to younger survivors. So if you're more used to maybe working with younger survivors of domestic violence or sexual assault or stalking, there are some unique vulnerabilities that older adults experience. And of course, not all older adults are going to hit these boxes, but they're just more likely to than younger adults. So they're more likely to have some physical disabilities, which might include trouble with mobility. So it's just harder to get out and access your services, harder to leave the situation they're in. They might depend on their abuser for their care, right? So now we have this abusive person who's been abusing them for years, has a lot of power over them, who is now their caregiver, right? That can create a very, very vulnerable, dangerous situation. Folks with cognitive impairments are at very high vulnerability for abuse. I recently saw a study that estimated almost 50% of older adults living with some form of dementia had experienced abuse, right? So we really want to look out for those folks. A lack of electronic literacy can isolate people. It can also just make it harder for them to access services and be able to find programs. And then when we're thinking of leaving these situations, finances are often a big part of that, right? So for older adults, they might not be working anymore. They might be on this fixed income, which makes it a little bit harder. Okay. So I'm going to get into the different forms of abuse and how this might show up. So physical abuse, of course, is the use of force to cause pain, harm, or injury. So some of the obvious ones you might think of are kicking, hitting, pushing, slapping, pinching. But this could also be the use of medications to harm someone, right? So maybe we have a family member who is trying to care for her dad, and she doesn't really want to pay for a home health aide, but she's going to leave him alone all weekend. So she gives him so much medication that he is sedated for the entire weekend, right? That would be a form of physical abuse. Or maybe her dad had an accident, right? He didn't make it to the bathroom on time. So the next day she's mad and as kind of revenge, withholds his pain medication from him, right? So any of this over or under medicating can be a form of abuse. It can also be unneeded physical restraints. So putting someone in a position they're not able to get out of, claiming they're a fall risk when maybe they're not at all. It could also be controlling access to someone's assistive devices or aids, right? So controlling when they're allowed to use their glasses, breaking their hearing aids. We had someone in our program whose husband would force her to walk without her walker, right? He decided when she was allowed to use that walker. So it was incredibly painful for her to walk without it. It was very, very slow. And that was certainly a form of physical abuse. Psychological or emotional abuse, while not physical, can be just as harmful for folks. So this could be ignoring the older person, right? Just pretending they don't exist, not allowing them to interact with friends or family, threatening them. So maybe the physical violence has ended years ago, but the threat of it is still there. Or it could be threats of hurting a pet, or threats of stopping providing care, or I'm going to send you to a nursing home if you don't do X, Y, or Z. Humiliating them, mocking them, treating them like a child. Harming pets is a big one that we see. And then also religious abuse. And I put that here under emotional abuse, but it could be its whole own slide. But religious abuse could be the older adult not being allowed to practice their religion the way they want to, not being allowed to go to church, not being allowed to pray or maybe eat kosher, or the abuser kind of using their religion as a way to shame them or keep them in their relationship, right? So saying things like, well, you made a vow under God, right, to be in this marriage and to be with me, and you have to obey that. Or, if you really were a good, Jewish mother, you would give me money when I asked for it, and you wouldn't kick your son out on the street, right? You would be there for me. And people are kind of saying these things and using religion in that way. So sexual abuse, this is any type of non-consensual sexual act, right? So either the older adult has said no, they've never said yes, or they're no longer able to say yes or no to what's happening. So this could be inappropriate touching, forcing the older adult to watch pornography or other explicit material, taking photos of them without permission. We've had reports of that in our program. We had someone whose home health aide was taking photos of her, actually exited the shower each day on the cell phone. And even in that case, which was so blatantly wrong, right? There was no real gray area in that situation at all. The older adult still really, really blamed herself for that sexual abuse and had a lot of excuses when she was talking to me and presenting it to me. So you can imagine if this had been her husband or her son or someone with a more complicated relationship, that report might never have happened. And often when we are hearing about sexual abuse, it could be months into knowing this client, right? It can be very, very difficult for people to disclose this. And often they're not using the term sexual abuse. It could be, well, this person bothers me, this person violates me, this person makes me feel uncomfortable. So look out for some of those things. Financial exploitation, this is certainly a big chunk of what we all see. The misuse of someone's money, possessions, or resources for self-gain. So it could be taking benefits. Had someone in our program whose grandchild rerouted the Social Security check, so she's got them all for herself. It could be controlling bank accounts or credit cards and just siphoning that money off for themselves. Forcing the older adult to change wills, property deeds, or other financial documents, maybe without letting them understand what those things are, or just forcing them to change them. Or taking possessions or money, or using coercion to get the older adult's money, right? So sometimes it's not, just a flat out taking it, but there's a lot more behind it, right? There's a lot of threats. There's a lot of things behind the situation that the older adult really isn't saying yes to what's happening. Then we have neglect. So this is when a caregiver, paid or unpaid, is really not meeting those basic needs. right? So not providing proper medical care or getting that medical care in time, not helping with dressing, bathing, or eating, maybe not getting prescriptions, not addressing toileting needs, or maybe making the person wait for long periods of time, locking them in the apartment or the bedroom, often saying, well, they're a wander risk, so I'm just leaving them there, but I'm locking the door, as opposed to getting help in the home, or leaving the older adult in the same position for long periods of time. And I always like to make the distinction with neglect. Sometimes this is very malicious, right? As a way to save money, as a way to punish the person. And sometimes it's not. It's not necessarily intentional. We might have a caregiver who really is doing their best, right? But it's still not necessarily enough that the older adult is not at risk. And either of those cases, we want to make that report and get that person to safety. We don't necessarily need there to be a bad guy in the situation to report. And then finally, self-neglect. So this is when someone is unable or unwilling to provide for their own daily needs. And I think these cases are often the most complicated cases because it really gets to self-determination and when and who isn't able to make their own decisions anymore. But this could be missing doctor's appointments, really not able to follow doctor's orders, not able to maintain their own personal hygiene or keep the home safe and clean, or being unable to manage finances. So I'm going to go into some warning signs of abuse, and then I think we're going to cover this a couple times to really hammer it home for you all. First would be any unexplained or untreated injuries that you're seeing in the patient or older adult. And maybe those injuries are explained, but the explanation doesn't quite make sense, right? So if you're seeing bruises, all over their neck or on both sides of their body, and they're saying, oh, I just fell, that doesn't really match up with what you're seeing. Broken or unused assistive devices or medical equipment, right? These things are constantly never available, always broken, never in use. And I'll just say before we go forward, some of these warning signs are big, flashing, oh my goodness signs, right? And some of them are a little bit more subtle, and some of them might not be signs of just elder abuse. They might be signs of other issues. We want to look at the whole context of what's going on. So any repeated hospitalizations, that could be a sign the person is continually getting hurt, especially if those hospitalizations are at different hospitals, right? Sometimes abusers will do that so the medical professionals aren't able to as easily kind of notice a pattern. Poor hygiene, right? The person looks like they're not caring for themselves in that way, or whoever is supposed to be is not. Dehydration and malnutrition, those can be really big signs and really serious ones. I had an eye doctor who recently talked to me about malnutrition in a client. He had a client come in, she had lost a very significant amount of weight in a very short amount of time. And when he talked to her about it, he didn't do any other screening for elder abuse, but when he talked to her about the weight loss, she told him that her home health aide had been stealing her Meals on Wheels, right? So she was not getting enough food every day. And it was just that weight loss that was his only sign to talk to her about that and ask more questions. Fear, right? Anytime someone is showing signs of fear when they are talking about going home or talking about someone in their life, or they stop talking as soon as someone comes in or start whispering, or talking about walking on eggshells in their home, that type of language. Any signs of emotional distress, agitation, withdrawal, depression, and anxiety. And I always say it'd be easy for us all, I think, if victims fit a pretty set role, right? If they were just very sympathetic and just crying and just wanting any help we could give them, right? But a lot of times people are stressed and cranky and irritable and kind of difficult to work with, but that's also them asking for help, right? It's just the stress in their lives and the trauma in their lives is just showing up in a different way. So we want to kind of look at all of those behaviors as asking for help. Trouble sleeping, big changes in their appetite, low self-esteem, if you have someone that you're working with that is talking about how they're such a burden on everyone around them, they'd be better off dead, they never do anything right, that language really might be coming from someone else in their life. If they're making kind of out of character financial decisions, right? So suddenly changing their will and putting it all to one family member or one new partner that they just started dating. If you are talking with a family or caregiver, noticing if they're just ignoring the older adult, right? Talking about them like they're not there, or if they're very, very defensive when you ask questions. If they don't allow the older adult to talk privately, right? They always have to be present, maybe even talking over the person. And do they describe the older adult using demeaning language, right? Are you asking questions about what the older adult has said, and the caregiver saying, well, don't listen to her, right? She's senile, she's demented, she doesn't know what she's talking about. And is the caregiver talking about being very, very overwhelmed, being unable to handle their role as a caregiver, right? Sometimes that's an excuse that we see abusers use, but it could also mean they're just overwhelmed, right? And they're not able to handle that role. And either way, we need to bring in more resources. All right, so with that, I'm going to hand it over to Ray. Right, there you go.
Sorry, I got it. So thank you. So good afternoon, everyone. I am Ray Leonard, and I am the manager of the Abuse, Domestic Violence, and Sexual Assault programs at Anne Arundel Medical Center. And I'm also the current vice president of the Maryland Healthcare Coalition Against Domestic Violence, which offers free statewide training for healthcare professionals on intimate partner violence. So the program at Anne Arundel Medical Center responds 24/7 to domestic violence, sexual assault, child abuse, trafficking, and vulnerable adult abuse. The goal of our program is to teach medical professionals the signs and symptoms of abuse and provide timely and effective response for patients. Hopefully, this response happens before the patient presents with an injury. We know that patients are often seen in a healthcare setting more than any other place, including shelter and other services. And our basic services include crisis intervention, personalized safety planning, safe discharge, mandatory reporting, advocacy referrals, and follow-up. Next slide, please. Oh, I'm sorry, stay on that one for just a second. So to give you an idea of our volumes, last year we provided services to 1,142 new patients. 106 of them were vulnerable adults, and 142 were over the age of 65. Next slide, please. So today I'm going to go over why screening for abuse is important, screening tools that you can use, how to successfully screen, and barriers to screening and response. So the importance of screening. So when a patient is asked about abuse, they become aware that, first of all, that it's a safe place to disclose abuse if something is happening, that that facility is a resource, and that it possibly has an impact on their health. Interventions, including safety planning, can prevent further injury or worsening injury. The Joint Commission does require a written screening for all potential victims of abuse. And for many people, it's the only place that they can seek help alone. So a medical facility is the only place where they would be able to disclose, because it's the only time that they're able to see another person or another person alone. And it also improves your quality of care. Next slide, please. So failure to identify the abuse can lead to missing pieces of the puzzle when you're in a healthcare setting. So could it be that the patient's diagnosis is a direct result of the abuse? So take a patient who presents with injuries like a broken arm or an orbital fracture. We would ask them how it happened and document if it was from a fall or a physical assault, right? But what about the cases that are not so obvious? So if a patient presents with vague complaints, such as reoccurring headaches, are they getting asked if they're being hit in the head? Or if someone presents with frequent urinary tract infections, typical causes such as hygiene, impact of incontinence may all be discussed. But what if it's actually their caregiver refusing to change them or help them to the bathroom, or making them sit in a soiled chair because they were upset with them or were punishing them for something else? Or even sometimes allowing them to get up to go to the bathroom, forcing them to have an accident, and then causing them to sit making them sit in a chair for long periods of time. Abuse can also interfere with a patient's treatment plan and management of chronic conditions. So if you have a patient that frequently misses appointments, does not follow recommended treatment plan, they'll likely get categorized as a non-compliant patient. But in reality, that patient may be dependent on their abuser to get to appointments, resulting in many missed appointments. They may not be allowed to go to the store to get their medication, or have access to funds to be able to buy their medication, or even worse, somebody might be stealing their medication or hiding it from them. They may be unable to access assisted devices like a hearing aid, so they miss information if they're say that they're at the doctor's office. They can't understand everything that the doctor just said to them. And there is a higher rate of emergency department visits and readmissions for patients experiencing abuse. Next slide, please. So how do we assess for abuse? So one way is to use screening tools. There are many screening tools out there that you can use. I'm going to show you some examples, but please note this is, it's just to give you the examples. There is information in the resource slides on how you can access them, and if you need any training to use them. Next slide, please. So screening tools are important because most people experiencing abuse would not identify as a victim. So the way that the questions are worded are not necessarily asking them if they're a victim of abuse. They're asking about the abusive behaviors. And one of the most common screening tools is universal screening. Most hospitals and healthcare providers are using it because it's short and simple. And so if you're asking a patient just if they're being abused, or if there's any domestic violence, or is your caregiver harming you, most of the time that they're going to say no because they don't identify as being a victim. But if you ask them, are you scared of anyone? They may say, yeah, I'm scared. I get scared of my son when he screams at me. Or has anyone hurt you or hit you? They may say, yes, my partner pushed me the other day and I ended up falling down and being hurt. So this slide is an actual screenshot of what we use in our emergency department. It looks a little bit different than that, but we created this and then also added some nonverbal identifiers so that even if the patient does not disclose abuse, you can also use this for identifying potential abuse. And a lot of those things are going to look a little bit familiar because some of those are the indicators that Sydney just reviewed, warning signs that she just reviewed. Okay, can you go to the next slide? So these are targeted elder abuse screenings that can be used in scenarios where you may have more time to spend with the person or do a further evaluation. So for example, the universal screening is only 2 questions. So if you wanted to take that a step further, you can actually use one of the targeted screenings to question the patient a little bit more in depth. So this is the EASY, which is for the Elder Abuse Suspicion Index, and the Weinberg Safety Screen. I think it might be a little bit hard to see the questions, but they're basically the warning signs written in question form. go ahead and go to the next slide. And these are targeted screening tools for domestic violence. And it is okay to use these for older folks as well. Somebody who's 65 may be experiencing some of the same things that somebody who's 45. And these will help to assess danger if somebody is experiencing intimate partner violence. Next slide, please. So there's also other tools that you can use. And when you are seeing a patient, other questions that you're asking them could go a step further to determine if somebody is being abused. Right now, there's a federal initiative to screen patients for social determinants of health, which are things like abuse and food insecurities and their social supports. So if you're doing a social determinants of health screening, you can go a step further. So for example, if a patient identifies that they have food insecurities, right? It may prompt additional questions like, can you afford to buy groceries? Can you get to the grocery store? Do you have transportation? If you add another question in there, is somebody keeping food from you? Is somebody stealing food from you? Sydney just gave an excellent example of somebody stealing a patient's Meals on Wheels, and they came in and were identified because of the weight loss. Another common question would be social isolation. So if a person screened in for social isolation, it may be because they don't have transportation. They don't want to be a burden on other people, so they're not reaching out and asking for help. But there's also the possibility that someone is preventing them from seeing their friends and family and isolating them. So regardless of what tool you use, your presentation, how you ask the screening questions, impacts whether or not that screening is going to be successful. Asking the question in a private space, maintaining eye contact, prefacing the question with a statement such as, we screen for abuse because it has an impact on your health and it's so common. We want to make sure that we're able to help you if you are being abused. And that will help build trust with the patient. So a couple of more tips are, don't make assumption about who is present with the patient, and use gender neutral terms when asking about abuse. So you may think that somebody appears to be their daughter when it may not be. So please don't make those assumptions that the person that is with them is safe. That person is very likely has the potential to be the abuser if there is one. Go ahead to the, oh, and please try to ask the patient without anybody in the room. If you ask them while somebody is in the room, you're not going to get the appropriate answer. So if you do get a disclosure or a response to any of the screenings, be sure to focus on what happened and not what's wrong with the patient or what they may have done to cause the incident to happen. So basically thinking, what's wrong with you versus what happened to you. You don't want to say to the patient, well, what happened? Why did they hit you? Why did they hurt you? But more so, what happens when your partner or your caregiver gets angry with you? How did they respond? So some of the barriers to screening, one of the biggest barriers that we see is that people, especially professionals, don't want to inquire about something they don't know how to respond to. So nobody wants to ask somebody and get an answer that they're just like, I have no idea what to do with this. So providing tools and effective response to screenings is important. We don't need providers or who's ever doing the screening to actually solve the problem, just understand how to identify, respond, and refer. Keep it very simple. So some of the other barriers, I will tell you that we had planned at Anne Arundel Medical Center on our acute care for the elderly unit to we had planned a rollout to increase screening on the floor, and we were going to use the Weinberg screening assessments. And when we finally got ready to go, COVID hit. So we were derailed, unfortunately, and now with staffing shortages, we have not been able to implement that. So hopefully we will be doing that in the near future. Some of the other barriers are the patient's condition may inhibit screening. And some solutions are, can you go back later? Can you make a little sticky note on the chart to go back and ask the patient later? Are there other identifiers such as the nonverbal identifiers that we talked about? Bruising on both sides of the body, bruising on the back of the body, injuries in multiple stages of healing. Time and privacy is also a huge barrier, especially in emergency departments. It's very difficult to get the space where it's quiet and private to ask the questions. And sometimes you genuinely may not be able to do a screening because their caregiver is there and you can't get them away. And so I would encourage, if there's any nonverbal indicators, that you make a point to try and catch that patient before they leave and try and do the screening. Some providers are in fear of offending the patient. Like if they ask the question, they're going to think that I believe that they're being abused. But if you preface it, like we talked about before, by explaining how common abuse is and that we ask all of our patients, it won't offend them. You ask them many other questions in the health assessment when they come in. And the hypervigilant partner is also a barrier, and that is the partner or caregiver that is answering the questions for the patient, not allowing them to speak, and you can't separate them. It's very difficult. If the patient is speaking, they may look to that person before they answer to get approval before they say anything. Some of the things that you can do in that, and this can also be used if you are having a privacy issue as well, is maybe move that patient to another area, bring them into the bathroom, bring them into another exam area and tell the partner you'll be right back, occupy them with something. A lot of offices now are doing bathroom cups. So when a patient goes to the bathroom to leave a urine sample, there's a red pen for people who need to talk to someone privately. And they leave that on the cup, and then somebody will come and talk to them privately afterwards. So I hope that made sense. So it's basically when you go to write your name on a urine sample, they have a regular black or blue pen and then a red pen if somebody wants to talk to someone privately. Just to clarify, I don't think I was very clear, so sorry. So, and how are you responding if you get a positive response? So the one thing is that if you get a positive screen, you don't need to provide this huge safety plan and all of these, connect the patient to all of these services. Acknowledge that the patient stated that they were being abused, validate their feelings and provide supports, and then assess for safety and refer to resources right there. You can let the patient connect with a hotline or somebody else that would be able to provide a safety plan if necessary while they're in the office with you. And document in the patient's medical record. And we'll go over that a little bit more in a second of what to document. So if a patient does not disclose abuse, but you do suspect that something's going on, you inquire a little bit more. Don't force them, but let them know that you're concerned and that if they ever need help, that you're here. Again, it's part of the education piece that comes along with the screening tool. Next slide, please. So documentation is important, and there is a lot of questions on how to document abuse and what to include. So the basics of documenting abuse is you should document injuries, marks, symptoms, and conditions. If the patient disclosed to you, you should use direct quotes. So for example, if the patient stated, "My caregiver refuses to help. If I have an accident, they make me sit there for hours before helping me change out of my wet clothes." That would be something that you would put in direct quotes. And then, oops, sorry. Also, when you are doing your documentation, you want to make sure that you're using neutral language. You're saying the patient states, patient declines, are better than alleges or refuses. So the patient stated that her caregiver forces her to stay in wet clothes, as opposed to the patient alleges that her caregiver is abusive. Patient declines to take a phone number for resources, or patient refuses to take a phone number for resources. So it makes a very big difference. And if the medical record should ever go to courts, the negative language can impact the court case as well. So please don't document any of the specifics of a safety plan, such as location after discharge. That's really important. You don't want to put in there. It's safe to say, provided safety information, or reviewed a safety plan with the patient, but do not put any location. And this is a screenshot from EPIC training module that shows how to make a note private. I know that there is new laws that don't allow you to make notes private unless you have a very good reason, and abuse and potential safety of the patient is a very good reason. So if there is a caregiver involved, especially with older folks, they are more likely to have someone checking their electronic medical record. So please make sure, if you have the ability, to make those notes private so they don't populate when a potential abuser is looking at the patient's notes. Okay, so as far as resources in the community, we have links in the resource slide again that will help you identify your local programs if you don't know about them. But I would encourage you to, if you don't know already, who responds to these types of cases in your facility? If you're in a hospital, who do you call? Do you call social work? Do they respond at all? Who is it that provides services? I would reach out to your local domestic violence programs and find out what services they provide. I would also find out services from the Department of Aging, and also to seek out your local ombudsman who is in the Department of Aging, and ask about community resources. A lot of hospitals and medical facilities are developing additional community outreach and some in-home services. So do you have something that is already available to you that you're just not aware of? Especially with COVID, a lot of programs that were started were stopped. So now is a good time to re-explore what the resources are. And finally, so as far as mandated reporting go, please keep in mind that unless the patient is a vulnerable adult or they present with an injury caused by a gunshot, deadly weapon, or vehicle, you should not report to the police or other authority without the patient's permission. So with that, I am going to turn it over to Greg. Thank you.
Thank you, Ray. And good afternoon, everyone. Thank you for joining us today. And special thanks to Bonnie, Sydney, and Ray. I'm Greg Sessick, the Director of the Office of Adult Services at the Maryland Department of Human Services, where I serve as the statewide administrator for Adult Protective Services. Next slide, please. The Office of Adult Services exists to protect vulnerable and elderly adults. We investigate for abuse, including sexual abuse, neglect, including self-neglect, and exploitation, including financial exploitation of vulnerable adults. I wanted to quickly cover some of our supporting programs. Maryland is really lucky to have a set of programs to support adult protective services. APS its purpose is to investigate. Often when we make a determination that we can indicate for abuse, neglect, or exploitation, or we can't, we can't just walk away from the individual at that point. We need to stay involved to help mitigate ongoing risk. We have several programs that assist us in that. One is just to continue on. We call that continuing APS. And that would be where we continue to work with the vulnerable adult, generally for a few weeks to a few months. This would be in situations where perhaps someone has been financially exploited. We want to work with them maybe to line up a power of attorney or to look for a more safe place for someone to live, or to provide some in-home services in cases of self-neglect. Adult public guardianship. We are the public guardian of person for new clients aged 18 through 64. The Maryland Department of Aging is the public guardian of person for new clients aged 65 and older. However, for existing clients at DHS, when the person reaches age 65, we don't transfer that case to Department of Aging. We retain that case based on the relationship that we have in working with that person. Guardianship is determined by the court, and there are two certifications of incapacity required, and I'll talk a little bit more about that in some of the future slides. Social services to adults. That is a case management program, a voluntary case management program, where we work with vulnerable adults around situations of less risk generally than APS. This is often combined with in-home aid services, or as we refer to it, IHOS. This is a limited home health care program where we can provide personal care to adults to safely age in place, because aging in place is either their choice or the only option they have based on their finances, other than living in a nursing home prematurely. Another program of the Office of Adult Services is adult foster care. This places an adult with a disability in the home of a provider, someone from the community who has the ability to take an individual or up to 4 individuals in their home and provide some structure. It's a great program. And lastly, respite care. The Department of Human Services is the state's largest provider of respite care, and that's a break to family caregivers. About 7 years ago, the Maryland Commission on Caregiving conducted a survey targeted to unpaid informal family caregivers. And the #1 request was, we need a break. And that is one of the services that the DHS provides. Next slide, please. Adult Protective Services is a social services program to assist vulnerable adults who are unable to meet their basic living needs, unable to access professional services, protect their own interest, and are subject to abuse, neglect, and exploitation. making them a vulnerable adult. And I'll go into the definition of vulnerability in a few moments. Next slide, please. The underlying principles governing adult protective services and all programs from the Office of Adult Services are the right to protection from abuse, the right to self-determination, and to stay in the least restrictive situation, as I talked about in the previous slide, really reducing the need for institutional care prematurely. Next slide, please. As Sydney mentioned on one of the slides from her presentation, we do receive more than 7,500 reports annually for APS. And in Sydney and Ray's presentations, they gave some very good signs of abuse. And I know for the participants on this call, you could probably give us some some ones that we haven't included. But I would like to point to a couple that we find particularly helpful to look for. Unexplained injuries, I know that was discussed. Unkempt appearance, inadequate or inappropriate clothing for the season is certainly something to look out for. Ray in her presentation talked about medications, taking someone else's or taking medication to which is not prescribed for you, someone who is over medicated or is not taking their medication is often a sign of abuse, neglect, or exploitation. And a big one, I'm sure, that we encounter, particularly in hospitals, is confusion. And what is the stem of this confusion? Is it because the person is lacking capacity? Is it a temporary medical a health challenge that we can screen for? Next slide, please. I want to point to our definition in APS of abuse, sustaining any physical pain or injury by a vulnerable adult as a result of cruel or inhumane treatment, or as a result of a malicious act by a caregiver, a parent, or other person who has permanent or temporary care or custody or responsibility for the supervision of a vulnerable adult or any household or family member. This includes sexual abuse. We have a very good trainer for our new hires in APS, who is our APS trainer for what we call pre-service training. And he tells all of the new hires, and this person, our trainer, is a retired APS supervisor. And he says, I'll tell you something that I tell my APS workers in supervision all the time. Every single investigation that we do, we should be mirroring a sexual abuse investigation. Be on the lookout for sign, particularly important. Abuse, the definition of abuse under APS does not include the performance of an accepted medical or behavioral procedure ordered by a healthcare provider acting within the scope of a healthcare provider's practice. Next slide, please. What is a vulnerable adult in regard to the APS definition? So a vulnerable adult is someone who lacks the ability to provide for their activities of daily living. Determination is related to the degree of mental and or physical disability and its impact on their ability to provide for their daily needs. To be considered a vulnerable adult by APS, a person must have a disability that results in functional impairment. Next slide, please. Neglect. I won't read all of these, but I just want to point to several points. Neglect is the willful deprivation of a vulnerable adult in regard to food, clothing, essential medical treatment, shelter, It was mentioned previously that, and this is certainly true in APS, often this isn't malicious neglect. We encounter frequently overwhelmed caregivers, and we do indicate, if we have the evidence, that the neglect has occurred, but we attempt to work with that caregiver in identifying the ways that we can assist in their care of the vulnerable adult. Exploitation, sexual and or financial exploitation. 10 years ago, Adult Protective Services was charged by the Maryland General Assembly for investigating for financial exploitation of vulnerable adults. We had not previously done that. In that 10 years, financial exploitation investigation and remediation now accounts for more than 30% of all of our work in the Office of Adult Services. So I ask you to think about on the second slide, that list of programs. It's pretty big. Financial exploitation is now 30% of all of our work. And self-neglect. This is the largest subset of investigations within Adult Protective Services. Often this involves some degree of capacity, which I'll discuss in a few moments. Next slide, please. So when should APS intervene? So I'll tell you our two response times. One is within 24 hours if this is a threat to life. Our typical response time is within 5 days. Within that response time, we have 60 calendar days to complete the investigation. For an emergency response, we have 10 calendar days. I want to read something from the statute. So APS intervenes when all four of these elements are present. Number one, the adult must meet the legal definition of vulnerability, which I discussed. There must be an allegation of abuse, neglect, or exploitation. Number three, the abuse or neglect must have occurred in the community. And number four, the abuse or neglect was at the hands of the caregiver or the vulnerable adult themselves, which would be self-neglect. Next slide, please. So this is discussing the vulnerable adult. Want to refer to Family Law Article Section 14-103, which states that Adult Protective Services investigation does not apply to the abuse of a patient in a mental health facility, the abuse of a patient in a facility licensed by the Department of Health, the abuse of a patient in a nursing home, or the abuse of a patient in a hospital. APS can investigate for neglect and exploitation, however. And certainly mandated reporters. I listed the citation, which include health workers, police officers, and now those who work in financial institutions, including banks. Next slide, please. So how to report? We've made this as easy as possible. Hopefully, we have a 1-800 hotline, which is 1-800-91-PREVENT. Or if you spell it out, 1-800-917-7383. What you'll need to do is identify the jurisdiction, if you know at the time, of the person who is the suspected vulnerable adult. Where do they live? We'll connect you with a person in that jurisdiction. And so what happens in this instance? So certainly we do accept any form of communication. I get for folks who work in banks or in hospitals, you might be able to give some information, but you don't really have a lot of time then. that's okay. Give us what you have. Give us a time, within a reasonable amount of time that we can connect to get more information and then follow up with a written report. Next slide, please. I want to fill you in on what happens when you report. So when the report comes into APS, we are making the determination whether this person meets our definition of vulnerability, if we have the legal right to become involved in someone's life, and are they at risk? So if we screen in an APS report, as I mentioned, we have a 24-hour response time or a 5-day response time, and either 10 days or 60 days to complete that investigation. Again, we're investigating for abuse, neglect, and exploitation, including self-neglect and financial exploitation. And our outcomes will be that this was indicated, which is a preponderance of evidence. 51% is preponderance of evidence that we are able to indicate this abuse, neglect, or exploitation, or that the abuse, neglect, or exploitation is unsubstantiated, or that we're ruling out the abuse, neglect, or exploitation report, or we are unable to complete the investigation. And an appropriate response would be if we did indicate for abuse, that we would make the appropriate referral to the state's attorney or law enforcement. That's within scope for APS. Next slide, please. So I wanted you to be aware of the tool that we use for the actual documentation in the APS investigation. It's called the Maryland APS Assessment Tool. These are the main sections within that. So we're looking at physical function, cognitive functioning is a big one. Who is the primary caregiver? What is the social and living environment and the financial circumstances? This is the tool that we use to document whether we can indicate for abuse, neglect, exploitation, or if it is unsubstantiated, or we're ruling it out because this is not a vulnerable adult. One of the things that often comes to light, I'm sure many of you on the call experience this, is capacity. Does the vulnerable adult have capacity? Next slide, please. Just as I know a lot of times in medical settings, in emergency rooms, you are not screening for capacity, but doing very much what APS is doing, which is screening for the need for a capacity assessment. So again, capacity, of course, is a medical term. It is complex. And who should be the person to provide that capacity assessment in order to file certification for guardianship. There should be 2 physicians. The best person is, of course, a medical professional who has been involved in the person in some way, who may know them and has tracked their progression in regard to incapacity over an amount of time. Next slide, please. Some of the elements of a capacity evaluation include physical examination, neurological examination, looking for medical situations such as dehydration that may be causing someone's confusion, which is not incapacity. It's a temporary situation that can be treated. I know that this is something that we're all involved in regard to evaluating for capacity, which is very important. I thank you for your time in listening to my presentation today. On the next slide is my contact information. Please don't hesitate to reach out. Thank you.
All right, thanks so much, Greg. So we are going to get into some case examples, get you all being interactive and hopefully using some of the tools that we all just learned. So first example, Miss Evans is an 82-year-old woman in the hospital for injuries sustained in a fall. You see that this is the third time she has been there this year for falling. She has bruises around her neck and around her wrists. Beyond her recent falls, she has had no major cognitive or physical health issues. When talking with Miss Evans, you notice that her husband continually answers for her and keeps a tight hold on her hand. When you try to direct questions to Miss Evans herself, she looks to her husband for approval. So first off, what would you do in this case? What would your first steps be? And please put those in the chat box. Get Miss Evans alone and ask her the elder abuse screening questions. Yeah, any other first steps that people might take in this case? Talk to her privately. Note her nonverbal cues. Yeah, that's great. Try to get her alone and ask her more questions. Talk to her privately. I would look at cultural difference. Yeah, that's a great point. Thank you. What are some ways in this case or in your specific setting that you might be able to get her alone? I could help her to the bathroom and ask her a couple questions. Yeah, thank you. So any other creative ways you might be able to talk to a patient alone in this type of situation? Just ask her. Yeah, ask her if she'd be comfortable speaking alone. Ask him to complete some paperwork in the other room. Yeah, so a couple answers here about paperwork, having the husband fill out the paperwork. It's a great idea. So what are some specific things in this case that would make you concerned? What are some of the things that maybe are jumping out at you that make you concerned for Miss Evans? Tight hold on the hand. Marks on her neck. Looking to the husband for approval. Constant falls. Bruises. So do you, looking at the bruises that she has, would you think that those bruises are consistent with falling? Does that, her specific injuries? Yeah, no eye contact. So one of the things we might also look in this case is she's saying that she fell, right? But the bruises maybe don't really make sense for a fall, right? So maybe these injuries are all coming in being reported as falls, but it's not necessarily a fall. Okay. So what would you do in this situation? If Miss Evans, you get her alone, she lets you know that yes, her husband does sometimes get physically abusive, but she wants you to keep it private. What would your role be in this specific case? Maybe people are typing or just thinking. I would respect her wishes and let her know about resources and safety, do a safety plan, focus on her safety and well-being, provide abuse hotline and information. Yeah, so a lot of resource referrals, provide resources. If she has capacity, then have to respect wishes, providing informed resources. Yeah, absolutely. So that's kind of the key in this case, right? She is someone who's experiencing what looks like domestic violence kind of grown old, right? But she has all of the same rights and ability to make her own decisions as far as we know as anybody else, whether she's 30 or 82 like Miss Evans is. So would this be a report to Adult Protective Services?
So that's a very good question.
Yeah, we're getting a lot of no's. What is your thought, Greg?
I have to agree with the no. Certainly you can report. You can always call the hotline.
Mhm.
Doesn't sound as though Mrs. Evans is a vulnerable adult in regard to APS. She doesn't have major cognitive or physical health issues. We certainly can make a referral to more appropriate reporting sources, but it doesn't sound like an APS screen-in.
Mhm.
Mentions the third time it has been reported for falling in a year. I'm wondering about who are the other people involved in Mrs. Evans' life? Do any adult children or neighbors ever come to visit without disclosing something that breaking confidentiality, trying to find what is her constellation of care? Who are her friends? What's going on here? It may come to light. The bruises around the neck is certainly hard to explain other than abuse in most situations, I would imagine. But what's going on in this situation? Is her husband overwhelmed and burned out in his caregiving? And try and find ways, I would imagine, to work with this family and see what resources can be made. As we mentioned, it doesn't seem as though she lacks capacity, so it certainly is. We can make a referral, and the referral is not is taken. So.
Thank you, Greg. Ray, do you want to add anything?
Yeah, so one of the things that I've actually seen providers do in a situation like this is actually ask the husband to step out, because they say they need the patient to answer the questions, because they are also doing a cognitive assessment at the same time. And if she can't answer the questions, then I can't do my assessment, so I'm going to need you to step out, which has worked pretty well in the past. And also very concerning is the neck and wrist bruising. It's fairly hard to bruise your neck, but is it an indicator of strangulation? Are they defensive wounds from something being around the patient's neck and them trying to pull it off or stop pressure on their neck? So and then with the wrist, of course, that can be somebody grabbing them, but was there any tying up or binding of the person? Because wrists and neck to a chair or a bed would definitely leave marks around your neck and your wrists as well.
Well, thank you. I'm going to bring it to the next case, and Ray, I'll let you lead that one.
Okay, so Joseph is a 45-year-old man in the emergency room after an accident in his home. He appears to be suffering from severe mental illness and or substance abuse. The EMS team reported that his home was inhabitable and it's unclear if discharge would be safe. So how would you approach this case? Yeah, further assessing what inhabitable means. Yes. Underlying cause. Assess what his medical needs are in relation to the discharge, complete a safe discharge planning assessment, and order appropriate consults to evaluate for cognitive ability, functioning, ask more questions. So what are some of the questions that you would ask? So can you provide additional information in reference to the home? assess if Mr. Joseph has any other family, friends, or contact. What does Joseph see as the problem? Ask about substance abuse. Anything else?
So one question I have, Ray, is
He's already.
situation in the case example a frequent occurrence? Is this a situation that happens with some frequency?
Mhm. And if there was frequency, if it happens, let's say 4 times in the past 8 months. So a couple people have actually put who called 911 and contacted the family. Was he already working with someone in the community? Okay. So would it be different if he was suffering from mental illness or if he was suffering from substance abuse? Would the approach be different or the same? Greg, I'm gonna hand that one to you, because what would make the difference if there is one?
So Joseph may be screened in APS. He is potentially vulnerable. He may not be able to make his own decisions. He may require a guardian. Guardianship is not forever in all circumstances. If this is because of an episode of psychiatric illness, then when that person is returned to more of a baseline, that guardianship could be terminated. That could be required in this instance. I think certainly looking at what's going on medically, a social evaluation, is the guardian someone in Joseph's life, maybe a parent or a sibling. Of course, if there was no one, then that may be DHS or Department of Aging. The difference between mental illness and or substance abuse, how would that impact how we would hopefully get this person to be safely discharged and where. That may be 2 different settings. So I think important to know what we're working with in regard to Joseph and his needs.
So Greg, I'm gonna pose another question to you. So let's just say that Joseph is actually, we determined that Joseph was actually intoxicated and that his issue is substance abuse. He appeared to be vulnerable when he came in because he does have some other health issues that are impacted by him using. And again, he's been here, let's say, for every other month. And the last 2 visits are getting a little bit closer together. So it looks like it's increasing in frequency. What would we consider Joseph a vulnerable adult then?
Good question. Thanks for the gotcha situation. So this may still be a situation requiring guardianship. So in the guardianship statute, one of the conditions is what we call habitual drunkenness. Okay, that would mean the substance abuse is resulting in Joseph's lack of capacity. That could be an appropriate guardianship. In regard to the does that make someone a vulnerable adult? Well, it could. I think we need more information in this case.
I'm just going to add a little bit more. By the time he is ready to discharge, he is okay to discharge home by himself with safe transportation. And then we see him again. So can you take it from there? So he returns 2 weeks later. This is a very common scenario, I think, in hospitals. And so that's why I'm asking so many questions about this, because it occurs frequently and it's difficult to determine.
Certainly. So remember, APS is, when we investigate, we are trying to determine whether someone is being abused, neglected, or exploited. With regard to what happens next, again, and unless and until someone's right to make their own decision is made, for instance, Joseph doesn't have the capacity to make his own choices. The only thing we can do in APS at that point is make a referral if we have been involved. Try to work with this person around finding a safe, least restrictive place to live. Looking at options regarding recovery, perhaps would be an appropriate role for APS. Certainly, working together in partnership as a system is, I think, what will result in the best outcome for Joseph.
So Greg, I have a question for you, just to jump off Ray's questions there. Obviously, the concept of vulnerability is really complicated, right? And it seems like it's always kind of ebbing and flowing and really difficult to assess sometimes. If someone calls up from the hospital, it's a busy situation, they're like, here's what's going on. I don't know if you'd consider them vulnerable or not. Can you all take it from there, or what types of things should they be ready to provide to help you all figure that out?
Great question. And that's something that call whether or not make the report whether or not you're clear. That's our job in screening to work with you. We have a standard tool, a risk screening tool, it's called, that we use in intake to help us make the clinical determination that this adult is vulnerable.
So one more question for you, Greg, following up on that. So Joseph screened out with the hospital, filed a report, and he didn't quite qualify as a vulnerable adult. But the hospital made a report to you, got screened out. Joseph's back again the next week. It deteriorates slightly. Another report is made and he doesn't qualify as a vulnerable adult again. But that third time that Joseph came in, he has definitely been in a rapid decline and would likely qualify as a vulnerable adult then. So my point is that if every time somebody comes in, is it worth filing the report?
Absolutely, it's appropriate, and many of us, I'm a social worker, many of us are mandated reporters. So we utilize at DHS digital data and case management system. And so we're able to see the history of involvement with persons who have come into contact with us. We can look at history, which is really important. Look at past interventions maybe that have been made involving APS or some of our programs. So certainly we're mandated to report, and the more information you can provide helps us make the best determination that we can, not only in investigation, but post investigation. I know resources with regard to where someone lives is critical. People tend to come to us when there's a crisis, and we make the best decision based on the information and the resources that we have at the time. I know that's probably a kind of an imperfect science as well, but one that requires us to work in partnership.
So don't give up is basically, don't make the assumption that nobody's going to help if you asked one time, because next time might be the time, and you're required to report. So I just wanted to put that scenario out there as well.
Absolutely. And one of these services we certainly provide when we can is information and referral. If this person does not meet our definition of vulnerability, we will try and identify this may be a resource, call here or here.
And just from personal experience, sometimes cases where the person may not qualify as a vulnerable adult, making that phone call can still provide a conversation that may give you the resources that you need. And I do that often with people who fall in that gray area. They're not quite vulnerable yet and don't qualify. So spending some time talking and seeing what is available and what would fit that person with their community partners is really important.
Absolutely.
So I think we're ready now for any questions that you might have. If you would put your questions in the chat, and I'll be monitoring those for our speakers. And while I have you, I have a few of you that still, I don't have your full name on the screen. And I have 3 of you that are logged in with a phone number. So if you plan to claim credits, I'm gonna need to match your phone number with your name. So we'll need that for the attendance report we have to send to our CE provider. So I'm writing you're putting your names in the chat. So Miranda Navarro, are you a phone number? Like everybody's putting their names in the chat for me, so I'll try and keep track of that, but I need to match it up with what you're logged in as or your screen name is. So I don't know, those of you that are putting in a name, if you're logged on with a phone number, I need the phone number to go with that if you're going to put that in the chat.
Bonnie, it looks like those folks are
Already
they're
on.
not, yeah, they're already kind of logged in.
Yeah, but the phone numbers are still showing, so I'm not sure. Angela, if you could tell me what your phone number is so I can put it with your name, that would be good. But any questions for our speakers? Oh, whoa, there's something there. So Greg, can you see those questions or, shoot, sorry for the dog. Can you see the questions in the chat or do you need me to read that to you?
I can.
Okay.
Mentioned that social services to adults component of adult protective services. There are a number of older adults in Montgomery County that do not qualify for adult protective services. Those who are cognitively impaired, vulnerable older adult. What is the best way to get these case management services from social services to adults for this population? Is it possible? When I've called Montgomery County APS, my older adult did not qualify. Okay. So when you make a report to APS and we identify that this person is a vulnerable adult and they're at risk, APS must respond. We must respond by law, either within 24 hours or 5 days, and complete an investigation. The other programs that I mentioned, well, except guardianship. Guardianship is a determination by the court that we become public guardian, and we must respond to that. The other programs that we provide: in-home aid services, case management in social services to adults, and respite. Those are programs that are voluntary programs, and we have a certain budget that's given to us to administer these programs within the year. That being said, we need to screen for the most at-need persons in the community. So sometimes that results in not being able to provide SSTA, as you mentioned, at that time for someone who is a vulnerable adult. We do sometimes rely on waiting lists so that when we have the ability to provide SSTA, we will call that person. If someone is put on a waiting list, there is a screening criteria that's based on the severity of their need. We look at that as well. So I think that's the distinction between the mandated services and APS and guardianship, or the supportive services. The supportive services, we really need to weigh, providing those services to the most in need in the community. Hope that helps.
Greg, there was also a question about different types of services APS can offer in terms of resources for a POA, living wills for older adults who may need those services but don't have financial resources or support to establish them.
Certainly. The best place to go for this information is actually the Attorney General's website. There's information on what a power of attorney is, what power you are giving someone over your life, that this should be a trusted person. That's where I would go to find that information. Yes.
And I see someone asked for the number. So you'll have access to this PowerPoint, which will have the hotline number there for you. Any other questions for Ray, Greg, or I?
Okay. Well, thank you three very much for a very informative webinar on this. As was stated earlier, we did record it. If you have colleagues that, would like to view it, we will get that posted. It'll probably be on our website as well as Sydney's website, and but they won't be able to claim credits for it. As a reminder, go to that slide that has the directions for your credits, and you have to do that within the 30 days to get those credits. If you have any questions in the meantime, feel free to email me, and have a great rest of your afternoon.
Thank you all. Have a great rest of your day, and thank you so much for joining us.
Bye.